Hi, my name is Rémy Duléry. I work in Paris, Saint-Antoine, and I would like to thank the AML Hub for giving me the opportunity to talk about sequential therapy for patients with relapsed and refractory acute myeloid leukemia. We just had actually a very interesting session at the virtual EBMT on this topic with Mohamed Moti, Guillermo Garcia Manero, and Ali Bazarbashi. Well, for AML patient in primary treatment failure, the chance to achieve a complete remission with standard treatment is 10 to 20% at best. Overall survival at 1 year is less than 10%. In case of failing one reinduction attempt, the probability of complete remission is below 1%, and new therapies such as venetoclax are not curative in this context. In light of these poor results with conventional therapy, allogeneic transplant is the recommended treatment. It represents the only curative option for the treatment of refractory AML patients. However, standard myeloablative conditioning is associated with toxicities, limiting its use in patients older than 50 years. And reduced intensity conditioning are less toxic, but they may not sufficiently control the disease to allow for the GVL effect to occur. These results led to the development of the so-called sequential conditioning regimen approach. It combines a short, intensive course of salvage chemotherapy to decrease the leukemia burden with a reduced intensity conditioning regimen and the use of prophylactic TLI. This strategy allows better disease control without increasing toxicity. The most used sequential conditioning is the FLAMSA regimen. It allows for an overall survival of 40% at 2 years and 32% at 4 years. A registry-based analysis by the Acute Leukemia Working Party of the EBMT has recently compared myeloablative conditioning to FLAMSA-based sequential approach. What it showed in about 1,000 patients younger than 50 years is that there is no significant difference in terms of disease control, in terms of relapse incidence compared to the two types of regimen. However, FLAMSA without TBI was associated with lower non-relapse mortality compared to MAC, resulting in increased overall survival. So it works better in younger patients, but in patients older than 50 years, it's also feasible to use it as myeloablative conditioning will be too toxic. The results achieved by FLAMSA are among the most promising, but it's still unsatisfactory in terms of long-term leukemia control. The incidence of severe toxicities related to azacitidine or total body irradiation impairs the overall safety and success of the procedure. Other approaches have been developed, either based on clofarabine or on thiotepa. In Paris Saint-Antoine, we use a thiotepa-based sequential approach, which uses thiotepa, cyclophosphamide, and etoposide, followed by a reduced intensity conditioning with fludarabine and busulfan. We published the result in 2018. We have a 2-year overall survival of 42%, and with longer follow-up in 67 patients, we have a 3-year overall survival of 36% and a progression-free survival of 31%. Finally, I would like to give some practical messages. First, sequential therapy should be proposed no later than after the second course of chemotherapy. A larger number of chemotherapy cycles before transplant is associated with decreased overall survival at the expense of a higher death from leukemia. Second, There seems to be no benefit in waiting for an unrelated donor when a haplo donor is easily and quickly available in relapsed refractory AML. We use the Theotypa-based conditioning regimen in haplo, and the 2-year non-relapse mortality is 15% in haplo compared to 31% with MUD. The GRFS is also significantly better in haplo than with MUD. So don't wait for a MUD, look for a family donor first. If you don't have a matched sibling donor, go for a haplo donor. Third, no matter the sequential conditioning regimen you use, an important part of this sequential approach is to enhance the GVL effect by using 2 levers. 1, prophylactic DLI, and 2, low-dose chemotherapy maintenance. The whole idea of the sequential approach is to better control the disease without increasing toxicities and allow for an early administration of a maintenance therapy, such as sorafenib or 5-azacitidine, and then prophylactic DLI. Well, I hope this short video was useful. Feel free to contact me on Twitter or by email, and I will be happy to answer your question. Thank you and have a good day.